Hello everyone, welcome to HIM 216. This is a continuation of the lectures covering Chapter 8 in your textbook. If you would please turn to page 158, 159 in your textbook. Basically at the bottom of 158, it talks about signs and symptoms and abnormal clinical and lab findings and Z-codes and the fact that they can affect any of the body systems. So there's not any anatomy and physiology specific to those particular codes. They cover all the body systems. The anatomy and physiology for the range of codes covered in these two chapters is actually discussed in the individual chapters for those body systems. On page 160, basically it tells us that there are Z-code guidelines, and those are also discussed in various chapters, but we're also going to go over Z-code guidelines in this chapter as well. You need to note the difference in a symptom and in a sign. A symptom is very subjective. It is what the patient complains of. You know, what are my symptoms? I have a sore throat and a headache and a cough. And then the sign is it's objective. And this is the evidence of the disease that is perceived by the physician. So you complain of a cough and a sore throat and a headache, and your physician examines you and he says, well, maybe you have bronchitis, or maybe you have strep throat, or maybe you have pneumonia. When we look on the center of page 161, and basically this tells you that, you know, it can be difficult to determine whether or not one of the signs or symptoms from Chapter 18 is routinely associated with a disease. And it tells you that you can reference the Merck Manual, which we have done, to see if those signs or symptoms are involved with or integral to a particular disease process. It reminds us that we can code signs and symptoms if there's no definitive diagnosis, if they're not integral to the disease process. When the classification system tells us to add those codes, or if the sign or symptom affects the patient's condition or treatment that they're being given. We do not code signs and symptoms when we have a definitive diagnosis or they're integral to the disease process. Now, you have some examples here that you can look at, and I'm going to let you look at these and read these yourself. They're very self-explanatory. And then it refers you back to Chapter 5 as well. For this lecture, exercise 8.1, I want you to answer questions 1 and 3. And now we're going to talk about abnormal findings and abnormal tumor markers, and these can actually be coded. There's not really a diagnosis. It's an abnormality, but we really don't know. There's no diagnosis associated with it. So if we in the index, we can type in the term abnormal. You'll see that there is an instructional note to see also anomaly. And some other terms that you might use is abnormality. There's also a term, findings abnormal. We can also actually look up. Of course we did abnormal. And in the example that we have, in the first example, the patient was seen by the urologist because of an elevated PSA. And we can actually type in elevated, and then PSA is prostate-specific antigen, so you can't type in PSA, but if you put in P at the very beginning of it, then you'll see that PSA is in parenthesis, and that code is R97.2. And then also the next one, abnormal lung X-ray. So if we put in abnormal diagnostic imaging, if we try to put in X-ray examination, it tells us see abnormal diagnostic imaging. And when we do that, this was a lung, and we go down and we will find that code R91.8. I want you to, next set of questions for this lecture, answer for exercise 8.2, answer questions 1 and 5. Now we're going to begin talking about the Z codes and the guidelines for the Z codes. Your book tells you that Z codes are used for circumstances other than a disease or injury. And we saw that as we went through chapter 21 and we looked at this chapter in the classification system. Now, these codes can be hard to find. Here on page 163 is a whole list of possible terms that you could look up to find these codes. I suggest that you flag this page in your book, or you put these terms on a note card, because you will definitely use them. I use them. Sometimes I have to come back to look at this list to remind myself of some of the different main terms that I need to look up to find some of these codes. We looked at the history of in the index. So we've seen that there's history of family and history of personal. When you go to these codes, for instance, if I go to history of an antibiotic agent, this one doesn't actually say personal history of. However, if we look at some of the family history codes, they very specifically say family history of certain disabilities. And we can go, let's see, let's find these categories in So when we choose the very last section in this chapter, we can see that there are specific categories for family history. And if we go through and we look at those particular categories, clearly in the title it says family history. Many of these with personal history say personal history. So when you're coding these, you want to be cautious if it's a family history or a personal history. You want to make sure that you're in the right section of you're in the right category for personal versus family, or vice versa. Now, we don't code every single personal history or family history if it really isn't relevant. So remember the definition of a secondary diagnosis. If our patient had pneumonia when they were 5 years old and it is really not impacting this particular admission, we don't need to code that there's a personal history of pneumonia. However, if we have a patient who has a history of breast cancer and they have had a mastectomy, those are both important things. We want to code the fact that they have a personal history of a malignant neoplasm of the breast, and then we also want to make sure that we code the fact that they have an absence acquired of that breast. And I can go to, if I go to absence, breast acquired, Z90.1, and then I have this specific codes for whether or not it was unspecified, right, left, or bilateral. Look on page 165. This first example is important because many times physicians will document that the patients have a history of blood pressure. And in fact, when you look at the chart, they're on blood pressure medications. They don't have a history of blood pressure, high blood pressure or hypertension. They have hypertension. So we're not going to code personal history of hypertension because they have it. It's being treated. Same thing in this example, it's COPD. COPD is a chronic condition. It can't be cured. It is usually progressive. So if the physician says, oh, this patient has a history of COPD, it's not a history of COPD. They have COPD, and you code that condition to an acute condition, not a history of. In the next example, the patient has a history of UTIs. They're not currently being treated for a UTI, so in this instance, we can code the personal history of a urinary tract infection. And then there are some other examples here of history codes. Now, looking at the beginning of the guidelines here on page 165, I want you to look at 21B. Many of these you can read yourself and interpret yourself, and I don't feel a need to have to go over those for you. When you look at B, this is important. Z codes aren't procedure codes. You have to have a corresponding procedure code. So you're saying, well, why would you be telling us that? Okay. We can code. Patients may come in specifically just for a procedure, like a tubal ligation. And so in ICD-9, we could look up desires sterilization and find that code. So for instance, if we put in encounter and then sterilization, we can find this code Z30.2. And this is a code for someone who is coming in maybe for a vasectomy or a tubal ligation. This is a diagnosis code. It is not a procedure code. We would also have to go to the procedure tab and apply the code for what procedure was performed. Now, keep in mind, someone coming in for a tubal ligation or a vasectomy, vasectomies are done in physician offices. CPT codes are used. If the procedure is done on an outpatient basis, we're not coding from PCS anyway. We're coding a diagnosis code from CM, and then we would have a CPT procedure code because it's not an inpatient procedure. Number 2 on the bottom of 165, code Z23 is the code for encounters for inoculations, and immunization. Encounter, administration. Okay, so encounter for immunization doesn't come up, but if I go to immunization, it says see also vaccination. And if I go to vaccination and then encounter for, it sends me to Z23. And you have an instructional note here, code first any routine childhood examination. And then it also tells you that procedure codes are required to identify the type of immunization given. And this actually would be a CPT code. It would not be a PCS coding. There's actually a CPT procedure code for giving the immunization, and then you also have a code for the medication. So there are actually at least 2 additional codes anytime someone receives an immunization on an outpatient basis. But these are not coded on inpatients. If someone receives an immunization while they're a patient in the hospital, those aren't coded. Nursing gives those immunizations. There is a charge for daily room and board, which covers nursing costs, and then out of the pharmacy, they will charge for the medication, and then there may be a supply charge. So in the inpatient setting, even if they receive immunizations, we do not code those. I want you to look on page 166. And this talks about the different status codes that we can use. And many of these are codes that we use regularly. And these indicate that a patient has had something done or they are a carrier of something. You see for status it has post in parenthesis. It also tells you, see also presence of. So if you can't find what you're looking for under status, you'll want to go to presence of. But for instance, if someone has a colonoscopy, a colostomy, I can do status colostomy, and this code indicates that this patient currently has a colostomy. If they have an ileostomy or a gastrostomy or a tracheostomy, this is a code that basically says this patient currently has this particular artificial opening. If a patient is receiving dialysis, but maybe you don't perform dialysis in your facility, but this patient is receiving dialysis, you can code the fact that they are dependent on renal dialysis. There is a DNR code, Z66. This is a patient who has signed a DNR status document in your facility. And when patients are admitted to facilities, they'll be asked if they want to be a DNR, and if they do, then the physician, when the physician writes the DNR order, it's based on documentation that the patient has provided. Just look down through these. Here is status gastric bypass for obesity. So this is a patient who's had gastric bypass surgery. Here's our HIV. They have an asymptomatic, they're HIV positive basically. Status breast implant. This is a patient who has had a breast implant. Status organ replacement. If a patient has a cardiac pacemaker in, there's a code that will indicate that they have that pacemaker. So I would suggest that you just take some time to go down and look at these status codes, because we use them consistently. So if a patient has had certain types of procedures, if they've had a coronary artery angioplasty, it tells us see angioplasty coronary artery. If they had a stent placed, it's with implant. They can have an angioplasty of another vessel that's not a coronary artery. That's why this is very specific to coronary artery, and then with an implant. If they've had a coronary bypass, here's a status code for aortocoronary bypass. So just all kinds of status codes that we code, that we apply. Now, I want you to notice that for some terms you have to put a dash between them. If I tried to put in just long term, it would not take me down there in the index. I have to put long dash term, and then it will take me down to these different types of medications. And so take a look at all these medications that you can choose from. And let me go to this particular category. Long-term current drug therapy. And this is long-term drug use for prophylactic purposes. If they're doing therapeutic drug level monitoring, then there's also a Z code for that. But you can see anticoagulants. So patients who are on Coumadin, there's a code for you to indicate that. People that are on NSAIDs, a code for that. Long-term use of antibiotics, birth control pills, insulin. Now the thing about insulin is that if a patient is a type 1 diabetic, they must have insulin. But type 2 diabetics, not all type 2 diabetics use insulin. So if you have a type 1 diabetic, there's really no reason to code this long-term use of insulin because they have to have it. But if they're a type 2 and they're using insulin, then we would use this code Z79.4. But that's only for long-term use. Sometimes type 2 diabetics come in the hospital for surgery or something like that, and they administer insulin because they want to absolutely control their blood sugars while they're in the hospital, but they don't go home on it. That's not long-term. A patient comes in the hospital, they're on antibiotics for pneumonia, they might go home on a prescription, but it ends. It's not long-term use. So you have to make sure that you understand what long-term use is. So long-term use of inhaled steroids. Aspirin is included in here as well, long-term use of aspirin. So opiate analgesia. So be very aware of those codes, and we can use those codes. We'll look at some of the other codes in specific chapters as we go through these different chapters. We'll talk about the resistance to drugs and things like that in Chapter 9. When we do the OB chapter next semester, we'll talk about these Z codes related to OB patients. We've talked about the do not resuscitate. Some of the codes that we use very, very consistently are the codes that, and those aren't here, so never mind that. Okay. Turn to page 169. And when you go to screening, you can find lots of codes related to screenings. Now, if we had an inpatient in the inpatient setting, would we use this? No, we would not, but we might use it in the outpatient setting. And so these are those codes for patients coming in for those kinds of screenings. And you can see they're in a category Z13, encounter for screening of other diseases. We have encounter for screening for malignant neoplasms, infectious and parasitic diseases. So we have a number of categories that deal with screenings. Now there are 2 observation codes, and these observation codes are used in a very limited situation. They are only used when a patient's being observed for a condition that is ruled out. You cannot use those if the patient has an injury or an illness or any sign of a symptom that's related to a suspected condition. In those cases, you actually have to use the diagnosis or the symptom code with an external cause code. These observation codes are only used as a principal diagnosis. So keep that in mind. You want to highlight that. I think you have questions in your workbook related to some codes that can only be used as a principal diagnosis. And these are in categories Z03 and Z04. So, and this tells you very clearly, this is used when a person without a diagnosis is suspected of having an abnormal condition which requires study, but after observation it's ruled out. And this is very important because sometimes patients come in with a diagnosis of suspected rape and they're examined and it's completely negative. Sometimes babies are infants may be admitted for a suspected condition that ends up being ruled out. So that's what these particular codes are used for. In category Z04, examination following a transport accident, a work accident. Here's the examination following an alleged rape, rape of an adult, rape of a child. Then there are codes for alleged physical abuse of an adult and a child. And of course, we would only use those codes if the physician came back and said, no, they do not have, they did not have any abuse. There are specific aftercare codes, and you can put aftercare in the index, and aftercare has a very specific definition. They are not used if treatment is being directed at a current acute disease. They are used when the initial treatment of a disease has been performed and the patient requires continued care during the healing or recovery phase. Usually the aftercare codes are first listed. Usually this is in the outpatient setting. And then and those aftercare codes explain the reason for that encounter. And then follow-up. The index refers to examination, follow-up. And you can see what types of subterms we have: chemotherapy, fractures, malignant neoplasms, so on and so forth. These are used to explain continuing surveillance after completed treatment of a disease or a condition or an injury. They tell us that the condition has been fully treated and it no longer exists. So don't confuse that with aftercare or injury codes, because follow-up means that the condition has been resolved, treated, patients no longer being seen for the condition, but they're doing a follow-up. And an example is follow-up after surgery. You know, sometimes patients will go in for a 5-year follow-up. Now, patients will come in as donors. They can come in and donate blood, bone. People donate kidneys. They may donate a liver or a lung, probably not as much as kidneys. I worked with a lady and there were 15 children in her family. Half of them had a genetic kidney disease, the other half did not. And so they actually had the testing done and they determined that every adult with functioning kidneys was an exact match to one of the brothers and sisters. So as a brother or a sister reached that point when they needed a kidney transplant, their sibling would go in and donate for them. And I had an employee working for me who was one of the good functioning working kidney siblings, and she actually donated a kidney to one of her brothers. I always thought they should write a book. I thought that was fascinating. Counseling codes, probably never used in the inpatient setting, but certainly could be used in an outpatient setting. We will talk about these Z codes on number 11, page 172, actually when we get into that chapter, but many of these are for outpatient settings. Z33 is pregnancy state, and basically this is pregnancy state incidental. We'll talk about that much more in that chapter. Same thing with Z34, and then of course the Z3A and Z37. There are some newborn codes, Z38. Every baby born alive has a principal diagnosis code from category Z38. And there are some nonspecific Z codes. I'm on page 175. If you look on page 175 at number 16, this lists the Z codes that can only be used as a principal or a first listed diagnosis. I want you to go to page 176 in your textbook. Exercise 8.3, I want you to answer 5 and 9 for this lecture. And we're going to go over 11 through 15. If I look at 11, it's Z44.109. Is this a first only listed diagnosis, or could this be a first and a secondary diagnosis? So I'm going to look on my list, my 16 on 175, and I'm going to see if Z44 is on page 175 or 176, and it's not. So now I'm going to look up that code in the index and go to the beginning of the chapter, and I don't see any instructional note that tells me to code first something else. So this could be either a principal diagnosis or a secondary diagnosis. And let's look at the next one, Z42.1. Well, on the top of page 146, there's Z42. So Z42 can only be a first listed diagnosis or a principal diagnosis. And then Z41.2, number 13, Z41 is not on that list. So if I put in Z41.2, this is encounter for routine and ritual male circumcision. There's not any code first note here. So that could be either a first or additional diagnosis. And then Z43.3. Z43 is not on the list. So if I go to Z43.3, if I look at this, look at my instructional notes, I don't see anything here about I have to code first anything else. So that could either be a first listed or a secondary diagnosis. And then number 15, Z34.01. So if I look at my list, I look on page 175, and there is Z34. So that can only be a first listed diagnosis. So let's go look at some other codes. So if I look at Z16, do you see I have an instructional note here, code first the infection? So Z16 could not be a first listed diagnosis code. Let's look at some others in this category. Retained foreign body fragments. I don't see any instructional notes with that particular category. Blood type doesn't actually have that instructional note either, but I don't know when you would ever have a first listed code for blood type. Let's look at BMI. BMI does not have an instructional note, but again, I can't imagine that BMI would ever be a first listed diagnosis code. Let's look at do not resuscitate. Nope, no instructional note there, but again, that is just the nature of that. It tells you it's not an encounter for or admission for or anything like that. So sometimes you just have to, for instance, estrogen receptor status, code first, malignant neoplasm of breast. So clearly this one could not be a first listed diagnosis code. So it's a combination of looking at your documentation, seeing what makes sense, and then reading your instructional notes. Now I want to go over the homework for you. In the chapter review exercises, you're doing odd 1 through 33. And I want you to keep in mind, what chapters are we coding from? We're coding from chapter 18 and from chapter 21. So you should assume that most of your codes will begin with either an R or a Z. That may not be the case for every single question, but definitely the majority of these answers begin with either an R or a Z. So when we look at questions 1, 3, and 5, they each have one code. Number 7 has 2 codes. And what you have to pay attention to here is this patient's coming in for insulin pump training, and they are a type 1 diabetic. That is 2 codes. 9 and 11 each have one code. 13, 15, 17, and 19 all have one code. Question 21. The patient came in for an elective circumcision. So you're going to have the diagnosis code and the procedure code. You need to code the circumcision. 23 is one code. 25, this has 2 diagnosis codes and 1 procedure code. So you should assume that when you're coding the procedure that your root operation is changed. This is a gastrostomy tube. It goes into the stomach, and the reason the patient has this gastrostomy tube is because they have dysphagia. So I will tell you that the first code, the principal diagnosis code for this example, is going to be a Z code. And then you'll have a diagnosis code and then the procedure code. Number 27. For this one, the patient is coming in for a vaccination for influenza. So this is a Z code as the principal diagnosis code. And then this procedure code actually is administration. We're not putting anything, we're not doing a transfusion, we're not dealing with an indwelling device. That only leaves physiological system and anatomic region. We're not irrigating anything, we're performing an introduction. And where are we introducing this substance? Well, it's the muscle. And so anytime you're giving someone a shot, you're putting that needle in through the skin and subcutaneous tissue, so it becomes percutaneous. That approaches percutaneous. And then for the substance, you need to see what substance here reflects that the patient received a vaccination. And then for qualifier, you need to see if any of these substances that can be introduced reflect that we reflect the vaccine, or if there's basically no qualifier for this one. For number 29, this patient is having a prophylactic removal of both ovaries because there's a strong family history of ovarian cancer and genetic susceptibility, so they do an open bilateral Salping oophorectomy. So first of all, we have a patient coming in for a prophylactic organ removal. That's a Z code. And why is she having it done? because she has a family history of ovarian cancer. That's a Z code. She has a genetic susceptibility. That's a Z code. Then you will have 2 procedure codes. So obviously there is not a bilateral Salping oophorectomy code. You have to code the right, and then you have to code the left. So you'll need 2 codes. Number 31, SIDS. I talked about this in an earlier lecture and what code you will use for that. And there's 1 code, and then for number 3, there is 1 code. Then you have a workbook assignment. And for this workbook assignment, you're going to be doing all the glossary definitions. There are only 4. You're going to be doing the odd coding questions 1 through 15. And I can tell you that for all of these, there is only 1 code, and they all begin with a Z. Then you're going to be doing the 5 multiple choice questions. And then you're going to be completing case scenario 5. For case scenario 5, there is 1 diagnosis code and there is 1 procedure code. This patient is coming in for seizure-like spells, so they do a video electroencephalogram monitoring. So we're going to be actually looking at the section for measurement and monitoring. And they did 3 episodes of video electroencephalograms over 3 days, and it didn't reveal any epileptic activity. So her diagnosis is just transient alteration in awareness. And then the procedure code that would be used for this, in reality, we probably would not be coding this on an inpatient. But we're not talking about a device, we're talking about a physiological system. And remember the definition of measurement and monitoring. We monitored because we did it over a period of time. And they were checking the brain to see if she was having seizures. So what body system would that be? And then when we talk about the approach, in order to monitor this, they put electrodes on her scalp. So what kind of approach is that? And then what were they measuring? They were measuring seizure activity, which that's the electrical activity of the brain. And then you will have to look at the qualifiers to determine whether or not there was a qualifier. And I'll just tell you for this, there was no qualifier. And then for number 7, a 2-year-old comes in for investigative workup for failure to thrive. They checked everything on this child. They looked for metabolic disorders, infections, intolerance to milk, other GI conditions. It was completely negative. So the diagnosis here is failure to thrive, and there's only 1 diagnosis code for that. So if you have any questions about this homework, please let me know. Thank you.